Welcome to our November Lunch and Learn, which is titled Touring Through the Front Line of the COVID-19 Pandemic in New York City. Our Lunch and Learns occur monthly and throughout the academic year, and really are meant to allow interested students, staff, and faculty to really learn from a member of the community who may be involved in work that's relevant to interprofessionalism or team-based care. Today's speaker, Dr. Dan Roberts, is a graduate of the College of Human Medicine in his second year of residency as a psychiatrist out of New York City. This past spring, as coronavirus was ravaging New York City, Dr. Roberts was able to really serve on the front lines of the COVID-19 response and work with a network of professionals that were caring for and helping those most in need during the pandemic. His work continues to still be very interprofessional, and he continues to see the importance of multiple professionals and care providers and really the care team in providing the best possible care to patients and families. So with that, I'm going to turn it over to Dr. Roberts. And for any of you that have questions, feel free to hold on to those until the end, and we'll have some time for questions at the end. So I will turn it over to you.
All right, thank you, Brian. I really appreciate the opportunity to be here. I really appreciate y'all, setting aside the time and tuning in for this. The Zoom format. This is the first time that I work on Zoom a lot, but this would be the first time giving a sort of a formal presentation. So played around with the format of it, and so hopefully it's engaging, comes through the way I intended. And then, set it up so that way we would have time at the end for questions, discussion. So again, I'm Dan Roberts. I'm I'm in my third year of training now at NYU, and I'd like to share a little bit about my experience, what I call touring through the front lines of the COVID-19 pandemic, and I'll get more into that. So let me see here. So just before we begin, everything that I have put up here, I can't take credit for most of the pictures. I have credit and citations where those are appropriately due. But disclaimer that I make is I have no financial disclosures, no conflicts of interest. And everything that I'm sharing here, while I am a resident and trainee of New York University, I'm not their official spokesperson. And part of that, I work from multiple hospitals. So the views and opinions expressed here are mine alone. So, just a little bit about me. Originally from the Midwest. I'm from Indiana, grew up there, did a little stint in Alaska during my 7th and 8th grade year, but lived in Indiana most of my life. Ended up I was in Indianapolis. And so then I, after high school, went off to Purdue. Graduated from Purdue, ended up, meeting my wife. Our next chapter took us up to Michigan, where I ended up going to graduate school for social work. I got my MSW and then ended up working as a social worker for a few years in addictions, mental health. Worked over in, if any of you are familiar, over by Livingston County, by Howell, in between East Lansing and Detroit. It was a really great chapter for me. Really enjoyed talk therapy, mental health, but sort of as I was going through my master's training and the clinical work that I was being exposed to, came across some great mentors. Got familiar with kind of what it sort of might look like to be a resident, to be in medicine, and so that planted the the seed for me to consider a career in medicine. And so while I worked as a social worker, I took night classes at Lansing Community College, and was able to get I remember it very fondly, marked on the calendar, and I got my acceptance call to be a part of the College of Human Medicine at NMSU. And so really special opportunity for me, and enjoyed my time in medical school. During my medical training, had the opportunity to come out to New York City, which I had never been to before, never visited, and fell in love with the city. So, coming to the city, and thinking about it, a really great place to train, to be exposed to a lot of diversity across the spectrum. And so as I was rounding out my medical training, I really had this hope and goal of being able to train in New York. And so I was really pleased when that came together. I back in March of 2018 had match day for medical residents. That's where I found out I was going to be moving to NYU to do my psychiatry training. And so just a little bit about that. Some of you, know people in healthcare. You're in healthcare yourself. So, I don't want to drone on about that, but essentially your psychiatry residency program is 4 years long. I'm currently in my 3rd year. Your first year of training can vary depending on the institution that you're at, but that's referred to as your intern year. And historically, that's where you as an intern basically lived inside the hospital. That's why they call you house staff. And you just did medical, surgical rotations, basically, kind of serving as the one of the cogs in the big machine of medical care. So your first year is your intern year, and you do a lot more, historically you would do a lot of general medicine. And so for my intern year, 6 months of medicine, and then after that, it has been psychiatry, purely psychiatry since then. One of the unique things about being at NYU is you get to work in a diversity of settings. And one that I and many people that train here are most proud of is being a part of Bellevue Hospital. That picture there at the top of the screen in the middle, those are the gates of Bellevue, which still stand to this day. But Bellevue is America's oldest hospital. It sort of traces its roots back to about 1736, and where they had a almshouse for the underserved, and they set up an infirmary, and that was sort of the inception of what came to be Bellevue. And if you think 1736, kind of wild to think that, right around the time George Washington was born, and then, about 40 years before the Declaration of Independence would be signed. So Bellevue has been around. It's pretty unshakable. And it's a great place to train because you see anything and everything, and Bellevue turns no one away. And so we have people come from all over the world to, receive medical treatment. So aside from Bellevue, which is a underserved public hospital, the picture on the left is NYU Langone Medical Center. And this is part of the complex. My opening title slide there showed the view of Tisch Hospital, which is part of NYU Langone. And this is where, more private pay patients would come for medical treatment. We do have psychiatry, all the different medical specialties at all the sites, but NYU particularly, very state-of-the-art technology, resources, and also great learning opportunity. And then on the bottom right here is the Veterans Affairs Hospital. Here in Manhattan, we have one of the largest VAs. It's sort of kind of, not exactly like swallowed up, but with funding being an issue, because the VA is part of a it's a federal program. The Manhattan VA has taken on the care of a lot of the surrounding areas, so it's one of the flagship VA sites. And so just to kind of anchor you, if you're somewhat familiar with New York City, this is all happening on the east side of Manhattan, about all the way from First Avenue and 23rd, which is where the VA is, all the way up to about 34th Street. So, that area has historically been referred to as Bedpan Alley. Similar there, in Grand Rapids to all the healthcare, the medical mile sort of setup. So really honored to be at NYU, going through my training, chugging along, making it through my 2nd year. And I also do a lot with research, and the way that my schedule had mapped out, I had deferred my vacations until the spring of my 2nd year, which would have been, I would have started in July 2019 in my 2nd year, and then that would have gone through June of 2020. So my vacations were set for the spring. In the springtime, caught word of, COVID, and was catching the news and sort of seeing what that would look like. One of my last memories in the city, I went away on vacation in March, and people weren't wearing masks at that point, but there was hand sanitizer at restaurants, like on every single table. That's sort of a memory that was standing out for me. So chugging along, then, my training, enjoying it, made it to vacation, got to exhale. Training's not easy, so it was nice to kind of recalibrate a bit. Then on my birthday, March 11th, 2020, it was, characterized, COVID-19 became known as it was characterized as a global pandemic. And so that's where things started to look really different, as you all know and went through. The world started shifting for us all. So, New York for me, the city as I knew it and fell in love with it. This is a picture of Times Square and kind of the stereotype of what people have of just a packed city, 24/7, anything you want, you can get around the clock. The city's got a pulse, it's thriving, very populated, but quickly thereafter, it really emptied out. When I came back from vacation, just shortly after March 11th, that's right when the stay at home order went into place. And so like my wife left, we left for vacation. She wasn't even able to like clear out her office or anything like that. She didn't know that she wouldn't be returning to her office. So the city quickly emptied out, to sort of a haunting degree. My wife is really into photography and videography. And so we actually went out one night and she put together a video. It's on YouTube, but we're riding our bikes around the city and, you essentially were just running lights. There was no traffic. Times Square was completely empty. And I don't know if any of you saw the movie, Cameron Crowe movie, Vanilla Sky, that, Tom Cruise was in. That historically he's got one of the more expensive shots ever made. And for about 30 seconds of footage in Times Square, where Tom Cruise is like the only character there, it cost about $1 million. And so, with Times Square looking the way that it was during the peak of COVID here in the city, a lot of people were referencing that scene. So, so the city cleared, I'll say this, people that had the means, places to escape to, places to go to, they did. But for many people, they didn't have that option. This is home. This is where they work and their livelihood. And so, things in the city started kind of revving up. This picture here, these are actually portable, these are like refrigerated trailers. Right near Bellevue Hospital is the New York City Medical Examiner's office. It's got a particular side street that is normally open to pedestrians and traffic. But once the COVID cases and therefore the COVID deaths started increasing, they needed places, the medical examiner needed places to store bodies, to do autopsies, to do work, or to just hold them until funerals could have access to them. And so that whole street next to that medical examiner's office, they filled it up with these trailers. Military came in to help out with this, and they actually built up a fence and put like sort of kind of camouflage netting over it to kind of draw attention away from it visually. And so that started really for me to kind of become very surreal. This headline, the quote here: "When you overwhelm the health system, you also overwhelm the death system," one funeral director said. So, I was looking back through the stats just to kind of, jog my memory and to get a sense, and so I was looking on the Google Analytics page, which sources, Wikipedia and other public health sites. But when I looked, it was around March 17th, got to a point where we started seeing like 1,000 new cases of COVID. And then right around April is where started to see this huge spike, which I'll have a graph later, but saw this spike where it was getting to be about 500 to 1,000 deaths per day. And that just continued to sort of roll on through April. So this was a really, really tough time and, sort of underscore, how sort of scary it was for people. I live right next to this, so it sort of kind of took on this surreal element of just kind of walking around, seeing this, seeing hospitals kind of build up impromptu tents. It was just like a very, kind of unnerving time. And so if any of you may have seen pictures of, they had these kind of impromptu morgues and trailers that they had to set up, but then they had a lot of unclaimed bodies. And, you know, if you've ever heard of like a potter's field, it's essentially sort of a gravesite or cemetery for unclaimed bodies. And these have existed throughout, you know, history in different cities. But this is a Hart Island. This is actually near the Bronx. And this is where they're burying unclaimed bodies. And I didn't look extensively into what that meant when I first heard unclaimed bodies. It's sort of, you know, kind of the reflex I had was, you know, all these sort of, you know, families with no, you know, or individuals who had died, no family or no loved ones, you know, sort of no plan in sight. I was just sort of picturing this being a bunch of kind of John and Jane Does. But apparently unclaimed is just for whatever reason. It's not to say that people don't have financial means or families, but they just didn't get an official like funeral placement in a funeral home. So, you know, and with the influx of deaths that was happening, you know, this was drone footage from one of these, you know, sort of makeshift cemeteries. So, you know, being in New York City, you know, I had friends from back in Michigan, from around the country who were, you know, texting, sending pictures. Hey, I'm seeing morgues, the military's moving in. Seems like New York's under attack by, you know, being ravaged by COVID-19. And it definitely felt that way, you know, and then, you know, but what was sort of fascinating and inspiring to me is, you know, the rest of the world heard that message, and then kind of came out to kind of hit the ground in any way possible. We had nurses, respiratory therapists, physicians, phlebotomists, you know, anybody involved in healthcare service in any way that they could, you know, came to the city to try to help out in some way. And, you know, that was really inspiring to see. You know, it was kind of, you know, there were, you know, reports of, you know, a lot of surgeons and operating theaters were closed. So, you know, you had people whose livelihood involved having a surgical practice, an outpatient practice. And so they, you know, kind of put that all on pause because, you know, COVID had shut a lot of that work down. And you would see, you know, attending surgeons, you know, you know, people who were very far along in their career and seniority coming to the hospital to, you know, draw blood and to help out, sort of, you know, not pulling any rank on anything. And it was really inspiring to see. Our hospitals here, you know, I'm part of NYU, they filled up insanely fast with new admissions. Unit after unit throughout the hospital was being turned into a COVID unit. You know, we had COVID units where it was new cases of patients with COVID being admitted, you know, and then we had ICU units, which were, you know, involved patients needing ventilators, had hybrids of this, and it was just really kind of feeling overwhelmed. You know, I'm in psychiatry, but a lot of my friends and colleagues who were on medical services, even some of the first year residents in psychiatry were working on rotations where they were working in the emergency room, working on the general medicine floors or the ICU. And you could just see the training program itself was being affected by COVID in an overwhelming way. It got so much to the point, like the medicine residents were getting sick with COVID, couldn't cover each other's shifts. Backup coverage was becoming a problem. And so then there's a governing body of medical residency training programs nationwide. And I didn't know of this up until then, but you know, there's actually sort of different states of emergency that you can go into. And so what ended up happening is my program and a lot of the programs in the city, if not around the country, went into basically this pandemic state where training kind of along the conventional lines was suspended. And so the medicine program was asking for volunteers from the other specialties in any way that, you know, any way that the residents would be willing to help out. They were looking for volunteers in hopes that it didn't get to the point that the, you know, the governing body of residency would then just have to redeploy individuals. And so some of you may have kind of, you know, personally been affected by this, had some loved ones affected by it, or just seen it on the news. There was a lot of talk of like redeployment. And so, yeah, the opportunity had come out for volunteers. I was on, you know, I'd come back from vacation, sort of was covering for the interns on other services and covering for my colleagues. Like some of my colleagues were, you know, they're going through a pregnancy or had, you know, chronic illness, autoimmune. And so we were covering for each other. And, you know, I sort of saw where that was going and sort of saw the city being overwhelmed, and, you know, was thinking to myself, like, you know, just like everybody else, I want to step up to do my part where I could most be helpful. And so I volunteered to go to COVID medicine on, as, you know, basically sort of, you know, at that point I was at the end of my second year, but I was basically signing up to be a medicine intern, sort of bottom of the totem pole. They called me, you know, a medicine super intern because, you know, I'd done my requirements of medicine and had training. So I wasn't starting from square one, but yeah, you know, I was, you know, it was sort of a scary idea, but it was, you know, it felt right for me. And so a number of my co-residents in psychiatry and across different specialties, we signed up to go to medicine. And so I'll talk about that. But this, you know, meme was going around, you know, which I think captures the sentiment a number of us had, you know, a number of us who have gone into psychiatry. It's not that we are anti-medicine or hate medicine, but drawn much more maybe to, you know, the psychological domain. Some of us not interested in doing procedures, certainly not interested in like critical care medicine or ICU level, particularly in the midst of a pandemic. So some of the anxiety, stay at home unless you want to be intubated by a psychiatrist. Thankfully, I didn't actually hear of any of that happening, but, you know, to kind of just make light of a grim situation. And I don't know if you could see this picture here, but one of my friends who also graduated from College of Human Medicine, it was emergency medicine doctor at a county hospital in Wisconsin. This particular Bane mask respirator that I have on there is not what we were wearing in the hospital, but COVID was so bad in his area and the work that he was doing, he had sent me one of those just saying like, hey, I know you're in New York City. You might need this at some point. And then, you know, this was around the time that I was working on COVID. So I sort of found some solace in reading Camus' The Plague, which I recommend if not familiar, if you haven't read it, or if it's been a while, just kind of revisit that to see what's going on, you know, at that time and place in this fictional context. It was, you know, surreal and eerie how much of it overlapped. And so I, you know, kind of found some solace in that. And so, you know, another thing that kind of, you know, that made its way around the national news is medical students were wanting to help out as well. Medical training was sort of put on pause, didn't want to increase exposure to medical students needlessly. And so, you know, what ended up coming to be is this opportunity to actually graduate early from training as a medical student and then start working as a resident, you know, getting health insurance, getting paid a salary. And so NYU, a remarkable medical school, and it's, you know, medical students are, you know, some of the best I've ever worked with. And so I wasn't surprised when many of them kind of took that opportunity. And so I had the honor to work with this individual here in this picture, Sam. He was featured in this New Yorker article. He, you know, did a standout, amazing job. And you know, my sort of shameless plug of myself is made it into his New Yorker article where he talks about, and I'll get into this more, but he talks about sort of the multidisciplinary makeup of our team. And he says his team included an older resident in psychiatry. So yeah, that's me there that he's referring to. So that's my claim to fame there for New Yorker status. So, you know, in terms of like pre-COVID and then what it all looked like, you know, how COVID and COVID medicine and what my time looked like, I'll go into that. So this is a couple pictures from the show House, you know, and so top left there, you have doctors in white coats, patient in the bed, and then House is the attending, the senior physician there. And so basically we call that rounding. You know, you would go room to room for all your patients that you're taking care of. And we would interview the patient at bedside. We would, you know, give the patient the updates. We would do teaching, discuss it. A lot of this would be happening at bedside or, you know, outside in the hall, in our team rooms. And, you know, it was very much, especially at an academic center, there was a rank to this. So as an intern, bottom of the totem pole, you know, you cover the pagers and you're putting in the orders, you know, what's called, you know, kind of historically referred to as scut work. You know, a lot of that sort of stuff, like kind of the, you know, the nuts and bolts of that makes this gigantic machine of medical care operate. You're the intern doing that. Then above you, you have a senior resident who is thinking through the cases, doing the medical management, running that by an attending who's the supervisor. And then we would consult physical therapy, order labs, or we draw them ourselves. Phlebotomy is, much better. Definitely much better than me at getting blood quickly, efficiently, painlessly. And so we would call in, everything, it was a multidisciplinary approach, but very siloed in a certain way. Everything was being done. We'd call, can you please do this? Can you do this? And that's how business was ran. And then, this picture on the right here just kind of reflects, this is a differential diagnosis where, patient's case, you list all the possibilities it could be, you talk through teaching, what rules that in, what rules it out. And so this was the day-to-day pre-COVID medicine on like a general medicine hospital ward. And then COVID very much changed things. This is, a group of clinicians, likely a mix of respiratory therapists, nursing, doctor, maybe, critical care doctor, even phlebotomy, everybody wearing the protective gear, in the patient's room. And this actually, in terms of what it actually looked like, the very disheartening thing about COVID was we were really trying to limit the exposure. We really sort of were kind of doing our best kind of, PPE precautions, hand hygiene, all of that, contact exposure, trying to be mindful of all of that. And so what that actually meant was, you'd have patients in a room, depending on, they'd be in a room by themselves or in a bigger, respiratory type room. And the amount of people that would go in, it was very limited and had to be kind of thoughtful and controlled. And so, when I went back to medicine as a super intern to serve on that, the way it was basically set up, I don't know if you could see that monitor behind the bed there where that number 70 is up on the screen, but those are hooked in, to a central source that we have access to in the medical record. So I had a list of patients, all, who had COVID on multiple floors of the hospital, but we had redesigned the electronic medical record to basically show like COVID data. And so I was able to monitor patients, in real time remotely. And so my doctoring, I essentially would call them on the phone. I would go stand outside their room. I was mostly doctoring remotely from the computer. I would personally only go in the room in emergency situations or patients that I was really worried about before the rest of the team got there, because I knew that, a senior level resident and attending on the team was going to be going into that room, as well as nurses, different specialists. And so we actually, I had to be mindful about providing good patient care, which I feel involves seeing your patients, talking to them face to face, but cutting down on the exposure risk. And so, it's not to say that I was kind of cavalier about my own exposure, but, it's, that part wasn't so much on my mind, but like the, PPE, you were hearing all these talks about potentially being limited resources. So every time you went into the room, you had to gown up with new supplies. And so to just have extra characters, even physicians and providers of all sorts going in, you really needed to pause to say like, is this what I need to be doing right now? Like to best serve the patient, the team, and everybody else. But what was really noticeable about going to medicine again during COVID is a lot of that academic sort of hierarchy was cut down. Everybody was on the same playing field. It was a multidisciplinary team. So, I had the Sam medical student who came on as, an early intern, had myself. There was a rheumatologist who came out of the outpatient clinic, gerontologist. We had medical providers from all over the country in all different specialties because, they had the medical training, they had the medical knowledge. And so, our team was basically, everybody was doing their part. So I would be on the computer putting in all the orders. The senior resident would be going with the attending, to see half the patients. The other, senior level clinician would take the other half of the patients. And we were splitting up, doing a lot of family calls, collaboration with palliative care. And throughout this time, you really got to know respiratory therapists, phlebotomists, physical therapists, talking with them to say like, what kind of schedule should we operate on? What's best going to serve our patient today? How can we cut down on exposure risk? And so it really, but my intern year of medicine was a very stressful time, sort of something to get through. I didn't love that piece of it because it's really hard work, very long hours carrying the pager, have 2 pagers, phones going off all day long. It's stressful. This felt very different. It was all hands on deck. People were just, were wanting to take care of patients, provide patients, and then go home and try to decompress for a bit before coming back and doing this with no sort of understanding of when the end in sight would be. We worked shift work, essentially sort of like 12-hour shifts. Then we'd swap out, to try to kind of protect everybody's sanity. Essentially working, 6 days a week. It was really inspiring being around everybody. And I really enjoyed it. And it didn't have that element of, sort of what we call pimping in medicine. Nobody was sort of quizzing you to kind of, point out everything that you don't know. It was just like a really great time. You could ask questions, you could get help from anyone. Everybody was just, if a respiratory therapist needed help, I'd, gown up and help out. It's like, it was just a really inspiring time to be there, to be a part of that. So, when I say touring through, I signed up initially for about 8-9 weeks of COVID medicine, which I was like, oh man, that's a lot to sort of go through, relative to what I was doing to be away from psychiatry. But that's what I was willing to do that. And it ended up being not all that, it ended up not panning out that way, the way that they were able to rotate some of us on and off. I ended up starting out doing, I did a week of nights over at the VA, and that was, it was an intense time because, those are patients who, maybe at baseline had a lot of medical comorbidities who were coming in the hospital. Some of them had orders like they didn't want to be resuscitated or intubated. Some of them didn't have family that could kind of speak to that. And so, we found ourselves in this situation of, kind of having to provide the best care available with the staff and resources that we had. And, it was pretty heavy at times with people dying. There'd be quiet nights, and then there'd be nights where it was just, case after coding, a code after code after code that, often did not end well. And so, that was tough to go through, but it was, really drew a lot of strength from working in the team setting the way that it was. So, you weren't doing this alone, and we're able to kind of get help and get moral support to kind of keep on grinding. So, it was really inspiring to see, like I said, people came from all over the country, and they were not afraid to kind of get their sleeves dirty. And collectively, the image I put here is that we all came together and gave it our Care Bear stare to try to kind of put COVID in check to get it down a notch. So that was, really fond memories that I have in a really terrible time. Like, I don't want to underplay how terrible it was and how serious the losses were for, a lot of people, and how traumatic that was, even for, on both sides, being a patient, being a loved one of a patient, and then traumatic for the providers, and so I can get more into that. But sort of just kind of going along, the amount of support and turnout from all over the country, if not the world. People were donating lots of money, and food, and restaurants were, because restaurants had been shut down, they were basically turned into food prep stations for hospital and healthcare workers. So every night, well, basically every meal every day in the hospital for all specialties was basically comped, and we were getting food from everywhere. And so, and that made people feel good. It was, nice. They would come with very lovely messages, and so that kind of kept us going. Lots of coffee and good food, not your kind of typical cold coffee and, generic hospital cafeteria food. So, and then maybe some of you saw around the world or on the news, maybe this was happening in your area, neighborhoods, but every night around 7 p.m., different, the city would basically go into celebration mode. And in New York City, that's a lot of fun because, there's people sort of, New York City is like a 4-dimensional area, there's people living on top of each other. So people were hanging out on top of roofs and basements and hanging out of windows, banging pots and pans, playing instruments, fire trucks, police motorcycles. We had horses, all kinds of stuff every night. It was a lot of fun in different groups, got recognized each night. So that was really, inspiring and a lot of fun to see. Had a lot of musical performers. So, the fire trucks would post up out in the middle of the street. This is a nurse here near Lenox Hill Hospital. So that was a lot of fun. It's cool to see the city come together and kind of make the most of a, very scary time of uncertainty. So, saying of how things looked in psychiatry, which looked very different than, a medical service, ICU service, intensive care, emergency room. Psychiatry, especially depending on the setting, looked a lot different. So in a lot of ways, most immediately when COVID came on, it was sort of like a ghost town. The emergency room, they were trying to cut down on the amount of traffic coming in. So, the emergency room, if you really weren't in the midst of a psychiatric emergency, like in terms of being suicidal, being too unsafe to be at home, they're really trying to turn you away to cut down on your exposure risk of being in the hospital. The inpatient units, any units that, were more, sometimes you could be admitted against involuntarily, sometimes you're in the hospital voluntarily. So depending on the hospital and the unit setting, they were trying to, a lot of units cleared out, because people had this thought, if I really don't need to be in the hospital right now, maybe I'm better off being at home, despite how bad I'm suffering. That's still better than being there and then getting COVID on top of it. So in a lot of ways, it was really kind of a ghost town. I showed you my hospitals that I worked at, or that I work at. Bellevue was not the case. Bellevue takes patients from all over. So as these other hospitals were emptying out, a lot of those patients were being sent over to Bellevue, or patients just would say like, I know Bellevue won't turn me away, or I know that there's more options over at Bellevue. But the VA, they were cutting, the VA takes a lot of voluntary admissions. And so a lot of patients decided not to go in. And they actually, at my Manhattan VA, they closed down one of the units. They consolidated 2 psych units just because the numbers weren't there. The inpatient unit at the private hospital at NYU, that was pretty quiet there for some time. And so they were rotating the number of staff that actually needed to be on the unit. But this changed a bit. The New York City subway is often a, sort of temporary bedding for a number of the underserved and disenfranchised. Our homeless population would often sleep on the subway at night, but they put in these orders, I think between like 1 and 5 a.m. and the subways were going to be cleared out because they were cleaning them throughout the night. And so, basically officers and such would go onto the subway and, remove homeless people. But, the problem there is where do you go? And so, a lot of the hotels cleared out in the city. And so they were actually repurposed as, homeless shelters. And, I say homeless shelters, but they were hotels, fully functioning hotels that allowed underserved, the homeless population to come in, because the thought was the actual homeless shelters were, all too much of a infection control risk. And that patients, a person staying there would be exposed to COVID and not be able to get proper care. So a lot of the hotels became temporary housing for the homeless population. And then, what I will say about, Bellevue, that is sort of another testament of Bellevue. Bellevue has a huge amount of psychiatric beds relative to most other hospitals throughout the country. And so Bellevue actually converted, some of its units to COVID psych units, and did a really great job of infection control, taking care of psychiatric patients that also got COVID. I worked in the psychiatric emergency room. So, we had our protocol for dealing with that. And, we would test patients coming in. We would admit patients that needed to be admitted, try, if patients weren't quite in that emergency crisis, if they could be managed with some step down level of care, we went that route. But, the other piece of this is it was hard to escape just sort of hearing about COVID, seeing COVID. A loved one maybe personally went through, were infected with getting, sick from COVID. And so, there were a lot of mental health concerns. People were, losing jobs, despair, hopelessness, not clear when this was going to end. So everybody, I think in some way, increased anxiety. There were reports of worsening depression, anxiety, sort of trauma-like symptoms, not full-blown PTSD, but a lot of the providers going through this, healthcare workers across the spectrum, were a lot of anxiety, panic attacks, recurrent nightmares. And so, you heard these numbers going up, and, I think what's particularly was tough about it is you were isolated, and there was no clear end in sight. And, and you heard reports about prescription medications going up, you heard of, reports of substance use going up. And so, it brought, as time went on through the months of COVID, it took more people into the hospital. And that's what we've been seeing recently. People showing up to the emergency room, just sort of like feeling untethered and, asking for admission, needing a place to stay, feeling unsafe at home. And so, the sort of business, the traffic that we're used to on inpatient psychiatric service, is returning to that level. And that was sort of, I only know from working at Bellevue and NYU in the VA, Bellevue just was pretty much didn't skip a beat. Things at the VA and NYU Langone have picked up since. So, and then I would say this too, on other services in the hospital, the anxiety, the mood symptoms, the trauma, that's pervasive, and so patients who were coming out of the COVID ICU or COVID who were admitted to medicine, psychiatry is being consulted a lot to weigh in on these cases. And so psychiatric consults, significantly increased. And, it was an interesting time. I didn't work on a consult service during that time. But, from my colleagues that did, some of the discrepancy in terms of how healthcare is delivered, they struggled with this idea that, they were supposed to work remotely through a video screen, which that entailed, having to have a nurse or a support staff put on PPE, get the iPad or the roving video unit, go into the patient's room, expose them, increase their exposure risk. Meanwhile, the psychiatrist is in, a workroom in the hospital or even at home or, somewhere else in the country providing this care. So, the healthcare delivery, it was kind of ever changing, and, we're still sort of figuring that out. And then, sort of where I am, I entered my third year, which is traditionally an outpatient year in psychiatry that started in July. And, that's a transition from inpatient psychiatric care to outpatient care. And this would normally involve patients coming in office to sit down and talk with you. I would see them for a mix of medications or therapy or a mix of both. But because of COVID, we don't see patients on site. It depends on the hospital. But at Bellevue, we are allowed to see some patients on site. We have patients who are high risk, or they require long-acting injectable medications, which they can't get elsewhere. And so we see them in person. Other than that, we do a lot of stuff on Zoom, or some other virtual platform. And it's an interesting mechanism, a platform for delivering healthcare. I think there's a lot of positives about it. For one, it's increased the compliance rate for showing up to appointments. Particular patients that transportation is an issue, finances are an issue. Having them travel an hour and a half to get to Bellevue for an appointment when they can just call from home has drastically, I think, improved the outcomes for a lot of people. And so that's been great to have that, whereas otherwise they might go, months of no-shows, missing their appointments. But, I had prior experience as a social worker working in person with individuals and groups. And so, some of my colleagues who this is their introduction to outpatient psychiatry, they only know it in this virtual space. And so it will be interesting to see what that adjustment is like for everybody, when we're able to return to inpatient or, in person. And so, there's a lot of, pluses and minuses of this virtual space. And so I think it's going to be, an ongoing study. But yeah, a lot of the work that I do now is I come in every day to an outpatient office. my office is in Bellevue, and then I connect on my computer for virtual appointments. And so, when I prescribe everything can be done remotely that way. So, but yeah, I have patients that I see every week. I have other patients that I see every couple of weeks or once a month. It just varies. So it's interesting, but, I think, if a successful therapeutic relationship is built around human connection, we're adapting to that, and we're finding ways to keep that connection going and to do important work. So, the other positive piece that I saw come out of this is in addiction medicine, particularly for patients who have struggled with opiates or heroin. There's medications like methadone or Suboxone, which are regulated in an even higher way than other medications, stimulants, other, controlled substances. And you often have to be part of a program. Place has to be a licensed facility. And there's a lot of barriers in place that maybe don't necessarily need to be, that have historically been instated, that have prevented people from getting care for substance use when we have good treatments. COVID lightened up a lot of those barriers. So, not only in mental health, were you able to treat patients in different states, you yourself could be in a different state, different video platforms. It wasn't so restrictive. We saw this with addiction medicine. And so it was easier for a lot of a lot of patients to get access to addiction medications. And so I'm hoping that some of those positive changes continue on. But we'll just have to see how that goes. So, maybe quite obvious to all of you, our work with COVID is not over. This is just a quick graph that I saw. I got this as of last night, where we're at in total US cases, and then cases here in New York and then New York City. And then it's nice to see that curve, trending down. We are starting to see it come back up in terms of new testing cases each day. So, and with it coming into wintertime and the way that, the annual waves of flu and the different respiratory illnesses that we would see anyways, I think a lot of people are concerned. So, time will tell, but, we learned a lot from this first surge, especially here in New York City. So hopefully, that information has been disseminated in a meaningful way that can hopefully affect some positive changes, so we don't, it doesn't look as bad or as dire across the country, across the world this time around. In speaking to, I truly believe, especially in a hospital inpatient setting, I didn't speak, outpatient psychiatry, I work a lot, especially now on video by myself, like me and a patient. But, for patients that are on antipsychotics, or, have other medical issues, I'm working with nurses, phlebotomists, other medical providers, but particularly on the inpatient setting, this is a very interdisciplinary, collaborative approach to healthcare, which I think is important, and it wouldn't function without everybody doing their part. So, I'm hoping with all of us coming together, continuing the work that we do in our respective specialties, but realizing this can't be done siloed. We need to work together. Hopefully we can contain COVID. So I appreciate you all listening to my talk. Bearing through this with me. I know the virtual format, we can't see each other, but I hope now with our time remaining that we can open it up to some questions, discussion. So yeah, I'll leave it there.
Sure. Kathy, I see that you raised your hand. Dr. Harrow, if you have any question, I think you should be able to unmute yourself. If not,
yeah, great. Thank you so much for sharing your experience. Really interesting to hear your perspective, especially during that really crisis mode that your city was in. My question is about the healthcare workers and kind of looking through the lens of preventative mental health for the healthcare workers, what you've learned about that and maybe what strategies may have been put in place. And once everyone got through the survival and the real crisis, it's still persisting and still climbing, obviously, with hospital admissions at an alarmingly increased rate. So what have you seen any strategies to really look from a preventative perspective at your healthcare workers' mental health that can be encouraged across the country?
I think, yeah, thank you for your question there. And I have seen positive changes from like a healthcare administrative standpoint, which have been somewhat reassuring for me. I've been a long time proponent of psychotherapy or self-care, like interpersonal sort of work. I think particularly anybody going into, I, anybody, especially going into healthcare delivery in any form. I think, particularly if you're working with patients on a close basis, I think it could be helpful to have gone through some of your own personal work, particularly in the mental health arena. And so I've been a long time proponent of, going through your own psychotherapy and, sort of framing that not as like you're in therapy because you have some psychopathology that needs to be worked out or there's something wrong with you, but, maybe just, you want to explore yourself to help mentally, or, you sort of want to kind of nurture resilience, self-awareness. And so I think particularly in healthcare, that could be an important piece, particularly for, individuals working in these kind of acute crisis, stressful situations. And I think that's what I saw sort of shift. So, like COVID swept in on the city, and, we were trying to do things in real time, all these impromptu groups of therapists and support teams kind of went online 24/7. We had respite rooms and just places that you could go in the hospital to sort of scream at the wall if you needed to, or just kind of take a nap or quiet down or talk with somebody. And then out of that, we saw, I think, more administrative support spreading in a good way to say, like, you know what, maybe, it's okay, like, to go talk with a therapist. Here's 10 introductory sessions of this type of therapy, or don't forget that your healthcare coverage has, mental health coverage in this light. And so it's been nice to see, I think culturally it's different. Like in New York City, in the media and whatnot, there's, a level of neuroses, on the coasts of how it's fashionable to be in psychotherapy. Like in the Midwest, it was sort of, it's not people were in psychotherapy. I was in psychotherapy as a, a social worker, medical student, but it was kind of more kind of hush I felt, to sort of talk about that. And so my hope is, in going through all of this, that providers can, administrators, teachers can, encourage people to seek support in whatever way that is, to try to help, kind of have a good offense going into these things, building resiliency, and then, sort of the damage control, and then the aftermath, like processing and integration. And so I've been reassured by seeing my hospital system in particular, some of the positive changes they put in place.
Great, thanks.
Yeah.
Thank you, Dr. Roberts. Any other questions? You could use the chat feature as well. Got about 5 more minutes here. I've got one, unless see if anyone else on the call. I was wondering, I know you touched on this a little bit, but how the telemedicine has really changed the ability of patients to be able to access care.
Yeah, so for all specialties, they pretty much have adopted telehealth in a remarkable way. What I've come to learn about it is, I think the VA, the Veterans Hospital in particularly, historically has done a good job of implementing that. So if you look at a lot of the data, the studies were done in the VA setting because they were trying to reach more of their veteran population in remote areas or in areas that didn't have access to different specialists. And so then now with COVID, pretty much every specialty has implemented telehealth, to a certain degree. Like mental health, I think there's a huge, I think it's a very powerful tool that needed to be there and has expanded access to, just in New York City, getting from one borough to the next can take a lot of time and, up to hours, and it can be very cost prohibitive. So for patients that can just stay at home and either have a telephone appointment, or if they have a smartphone or a computer, they can have a telehealth appointment. And that counts as I do 45-minute therapy appointments with my patients. And so that gives us 45 minutes at the very least, to connect each week. And I think it's helped with, reminding patients to take their medications. I think it's increased compliance with medications for other medical conditions. and hopefully we'll start to see some better health outcomes translate across the different medical specialties, whereas, if you had your doctor that you see once a year or once every other year, and you don't really have a personal relationship with them, it might be easy to kind of scoff off that annual checkup appointment that you have. But you could do that through telehealth, and you get a reminder of it and everything. It's like, oh, a nice way to check in and to, just make sure that, the health parameters are being met there. So I have heard of, like, I was thinking, I'd heard of an orthopedic surgeon who has a, telehealth, right? Like, that's a surgical specialty is kind of limited by what they can actually do. But in terms of the actual medicine piece, I heard of this orthopedic surgeon, who was basically having a family member do these orthopedic maneuvers on a knee joint, and was like sort of trying to listen and kind of see how it moved, and so there's definitely limitations. I hard to imagine doing physical therapy in a lot of ways with telehealth. And so, the luxury of telehealth, I think, it's not, equal across the spectrum of healthcare delivery, and so my comment there of like the consult psychiatrist being able to kind of view that remotely, is not meant to be critical to CL psychiatry in any way, but there is a bit of a disparity there, where not being the person to go into the room to actually set up the equipment for the patient to be able to connect with the provider, but nonetheless expanding the access. A provider sitting at a computer can kind of rapid fire a lot of these visits and appointments, in a good way. So I'm hoping that the positives of telehealth will continue and expand. And, hopefully we'll get more data too to let us know if, it is having a positive impact or if it is having a negative impact, what that looks like.
So our last one as we wrap up from one of our participants in the call here was wondering, they're curious how you think your history working in the Livingston County area has helped your view or work with COVID.
I think what most immediately sort of spoke to me about that, like I graduated from my social work program on a Friday and like went to work on Monday. And that day they were like, oh, hey, you're the new group substance use therapist. And, I was like, I've never done some groups, but like, I certainly wouldn't advertise myself as a group substance use leader. And so sink or swim, and sort of ditched the tie right away because, I had more to learn from my patients and clients, than what I needed to read to them from a book. But like what I learned was, it was amazing the trials and tribulations, particularly in Livingston County. It was kind of that across that spectrum, which resonates with my experience here working at Bellevue and then private hospitals. Patients that had means that were affected by addiction in the same way that patients that didn't have means were affected by addictions. And so, that period of working in Livingston County for me was just, that we're all in this together, that we all have our struggles, and that we all, the human connection is, I think, what best serves us. And, we're all here, in my opinion, to kind of coexist and try to help each other.
Great. Well, we'll conclude with that that final thought, and I just want to thank Dr. Roberts again for your your insights and really excellent presentation about your experiences in New York. And I thought it was really interesting how COVID has removed some barriers in some ways, or sped up the process for some of these other innovations or positives in terms of access to care that you talked about towards the end. And so that was interesting to see as well. And certainly the ways that interprofessional teams were called upon to really care for patients and really lead to the best possible outcomes in terms of caring for the most critically ill. So I just want to thank you again for your time, and
thank you for this opportunity
and do the great work that you're doing out in New York. And certainly if anyone on the call has additional questions, I'm happy to put you in contact with Dr. Roberts. But with that,
oh yeah, please, I'll let you kind of field those, and then you can direct them my way. I'd be happy to email or text, etc. So
excellent. Well, thank you very much, and We
Thank you all.
the best for everyone, and we'll see you next time.
All right, stay well.